We're there. It is noon, and I think we'll begin. So again, welcome to all of you who are joining us this afternoon. I'm Molly Stearns, and I'm the chief. Okay, I'm the Chief Development Officer here at Overlake Medical Center. Most of you I know, and for those of you who I haven't met yet, I hope that we can have an opportunity to do so soon in person, and not just on a Teams call, which I think we are all now used to, but at the same time probably getting sick of. I'm going to turn this over to Mike Marsh, our CEO, who will go ahead and offer a few remarks and then introduce Dr. Ron Aviles, who will start off today's program. Most of you also know Mike, and if you don't, like myself, I know he is anxious to meet all of you in person at some point. I think over the course of the last couple of years, I think we've all become familiar just in terms of just teams. But Mike has been at Overlake for over 8 years now and has just made a huge difference in our program here in all aspects, and not the least of which is our cardiovascular program. And with no further ado, Mike, I think I'll turn it over to you. Hello. And if you could welcome everyone, say a few words, and then turn it over to Dr. Aviles, who we also see on screen right now. So that's great. Thank you. Mike, you're on mute.
Yeah. Sorry about that.
It's your first Teams call, we realize.
I know. Well, thank you, Molly. And to everyone, welcome to the Circle of Excellence, this version of Circle of Excellence. Our program today will focus on our vision and the future of cardiac care at Overlake. You know, before I introduce our presenters, I never want to miss an opportunity to thank you and express my deep appreciation for your support as donors and corporate sponsors. Without you, Overlake would be incapable of providing the kind of world-class technology and treatment that it does today and will into the future. Services exactly like what you're going to hear about today. As Molly said, we are once again really pleased with the great response and interest in these Circle of Excellence presentations. Although we're still not ready to meet in person, we look forward to the day that we will be able to do so. But for now, we all know the drill regarding virtual events. So I won't go through that drill with you. Today, you'll hear from Dr. Ron Aviles and Dr. Robert Riley, both highly regarded and highly subspecialized cardiologists in our Overlake Cardiology Division. I will introduce Dr. Aviles, and later Dr. Aviles will introduce Dr. Riley. So first, it's a great pleasure for me to introduce Dr. Aviles. I have known Ron since I arrived at Overlake 8 years ago. He literally was one of the first physicians I met. What is most impressive to me about Dr. Aviles is that he's not only an extraordinarily talented clinician, but he is a visionary. In addition to being a visionary, Dr. Aviles has held multiple leadership positions, including serving on the Overlake Board of Directors for 8 years, just completing his last term in December. And also in December, just coming off a 2-year tenure of being Overlake Hospital's Medical Center's Chief of Staff. He's also the program director for all of cardiac services and the medical director for our structural heart program, which he, along with Dr. Scott Haugen, a cardiologist from Kaiser, founded 7 years ago. Some of you also know that program as the first procedure coming out of that program was our TAVR procedures. He's also my neighbor, but I'm not sure that has made its way onto its CV. But I thought I'd throw that in as well. So now I'll turn it over to you, Ron, and thanks for being with us today. Appreciate it very much.
Just thank you, Mike, so much for the kind introduction. You know, just so you all know, I'm going to tell you a little bit about Mike and his December lights. I'm going to tell you all that he lights up the neighborhood with Christmas lights like no one else. My kids have a delight in watching the lights in Mike's home. So with that, I also want to join Mike actually in thanking everybody for the kind support throughout the years, that have been in leadership at Overlake Hospital. We can't do what we do without partnership, with our community supporters. This hospital was started by physicians that wanted to bring care to the East Side and community members who wanted to support him to do such a task. And so that support has been a constant, for all of us at Overlake, and we are grateful for you today. So I also want to thank Stephanie and Alex and Molly for giving us an opportunity to chat about cardiology. I jump on those actually because it's a delight for me to really brag a little bit about what so many of us at Overlake in cardiology have been dedicated to doing to serve the interest of our community. So thank you, Stephanie. Thank you, Molly. Thank you, Alex. In the last 7 or 8 years, we have been engaged in developing our vision and mission for cardiovascular services at Overlake Hospital, and the vision is a very unique identity. It's born out of a very unique identity of who we are. We are a unique community center because we are not only available to patients. Your attending is available to you quite readily, unlike a big center, like the bigger center like the University of Washington. But we also, despite being a community center, a community medical center, we are able to provide tertiary services, and there's not another center that does that in the greater Seattle area that is community, but yet with tertiary capabilities. And over the last 7 or 8 years, we have been adding those tertiary capabilities slowly over time, thoughtfully and carefully, and bringing in the right people to deliver those advanced services. We started, as Mike said, with the structural heart program, which is, and the procedure, the marquee procedure there is the TAVR, the transcatheter aortic valve replacement program. And we've added some more to those procedures that we do within the structural heart setting, over time. And we added an advanced imaging program. We improved our capabilities in the electrophysiology subspecialty. We are in the beginning stages of developing our heart failure capabilities, and I'm delighted today to share with you what we're doing in the complex coronary artery setting. So the complex coronary setting is a very unique environment, and I'm sure that Dr. Riley is going to explain that a little bit better than I am right now. But traditionally, when people have blockages in the coronary arteries, we approach it through, conventional catheter-based techniques or through cardiac surgery. Well, it turns out that these two modalities to open up arteries don't quite meet and form the tight circle that we want them to meet. There's a gap between the two traditional techniques where at times cardiac surgery cannot really achieve the type of blood flow delivery to the heart muscle that they would like and cannot be done. And sometimes catheter-based techniques are not able to achieve that level of improving blood flow to the heart muscle in the right clinical setting that we want to achieve. And there's this gap in between the two techniques to deliver blood flow to the heart muscle. And that's where Dr. Riley comes into play. There's this growing field of complex coronary revascularization where we're able to, through advanced and novel techniques, to be able to deliver blood flow to areas that traditionally we haven't been able to do so effectively. And so that's why I'm so excited to introduce to you Dr. Riley. He is a national, not only a local expert in this area, but he's a national thought leader as well. He sits in multiple national societies to advance the field and through his engagement with these societies. But more important than that, and Robert knows this, from our engagements, he's a man of great character and a partner and a good friend, and that to me is even more impressive that what he has done so far in this growing field. So we're excited to have him here today. I'll let him tell you a little bit more about himself and let him tell you a little bit more about this other tertiary capability that with his skill set we're adding to the overall cardiovascular vision that we're able to deliver to the East Side. So with that, Robert, so glad to have you here. I'm excited to hear what you have to share with this, with this very engaged and very supportive community of partners that we have today.
Well, fantastic. Well, thank you so much, Ron. Can everybody hear me okay? Yeah? We get a thumbs up?
Yes.
Okay, great. So again, thank you all so much for having me here today. I've recorded the intro Ron just gave me so I can have my own little Rocky moment in the mornings in the mirror before I come to work. So thank you very much for the kind introduction. I'm sorry that we all can't be together today. These types of things are really rich in person, but we're going to do our best to sort of cast this vision and really go over in a little bit more detail what Ron and Mike were just discussing. Thank you all, just to get started, for being here. These are challenging times. They've been challenging times for a lot of us in a lot of different ways, both personally, professionally, and healthcare delivery has been particularly challenging. And I think one of the things over the past 2 years that we've really learned is, healthcare is really a community event, particularly here at Overlake. We cannot do what we do without our community partners, such as you, such as the people on this call. You all are really a foundational building block for what we do on a daily basis. And I think we've learned how much more important that was even over the past couple of years. So again, thank you guys so much for being here. So let's talk a little bit about this novel program that Ron was sort of discussing, this what we're going to call the Complex Therapeutics Program. It's a mouthful, so we're just going to say CCT here for the time being, but I really want to take a minute to focus on what that means. Complex, meaning different than what we already have. Coronary, meaning mostly focused on the coronary arteries, so the arteries that feed the heart muscle. And then therapeutics, meaning that there are a broad variety of things that really go into this. Balloons, stents, machines, all sorts of things. We'll talk a little bit about that without getting too much into the weeds. A little bit about me. So I grew up in the Southeast, East Tennessee, educated in the Southeast, University of Virginia, and then came out here for residency at the University of Washington, some fellowship training as well. Was out here off and on for about 10 years roughly, and then transitioned back to Ohio to have a few kids. Decided that our family missed being in Seattle, and so we've made our way back here to Overlake. And when we looked at the lay of the land here in the greater Seattle area, really Overlake was the partner that made the most sense for developing something novel, something that we could really meet patients where there was potentially a care delivery gap. And so we're going to talk to you a little bit about that. This is just a basic outline, again, talking about what we're going to be looking at programmatic-wise. So first, we start off with the impetus for a program. If there's not a good reason for something, the rest of it's a little bit meaningless, right? Then we're going to shift over to the kinds of patients that meet that impetus, what it looks like to develop that type of program here, some case examples, and then really what the partnership with you all looks like in building this program. Again, this program is not a physician or a team of people at a hospital. It's a community-wide event, which is why meetings like this are so, so important. So let's talk about the impetus first. Don't have to be a doctor to know that heart disease has been the #1 cause of mortality or death in patients in the US for a very long time, and that's not going to change anytime soon. And in fact, coronary artery disease is the most common cause of death in adults in the United States. The challenge with that is that we've seen that the complexity of the disease in the heart arteries continues to increase over time. And this is actually some older data, and we've continued to see this for over a decade now. Disease is getting more complex as we go along. And so then the question is, well, why is that? Well, again, for better or for worse, in America, we continue to have increasing comorbidities, meaning medical problems. So we're seeing increased rates of diabetes, high blood pressure, kidney disease, and all of these things directly affect the heart. And this is sort of an overlapping Venn diagram where one thing affects another, which affects another, which affects another, and they all come together and show us sort of how our disease continues to become more complex. With that increased complexity of disease, we also see that the anatomy of the arteries, so the disease burden becomes more complex. And then you see on the bottom right, we're needing increasingly complex equipment to deal with patients who are increasingly sicker and who have increasingly difficult disease to treat. The challenge with that, though, is the number of procedures we're doing to treat artery disease continues to either plateau or slightly decline in all major markets across the United States. And one thing we know, both in medicine and out of medicine, is the more you do something, the better you are at it, right? That's true if you fly a plane. It's true if you hit baseballs. It's true for a variety of things. And that's not exclusive to healthcare delivery as well. We see that in the number of surgeries you do. We see it in the number of stents you put in. That's particularly true in the number of complex procedures that you do. So we have this potential patient care gap that has been evolving where our patients become increasingly complex, our volumes are somewhat stagnant, and so we have a potential decreased ability to meet our patients' needs because of these two overlapping issues. So when Ron and Mike and the leadership at Overlake looked at this, we realized that there's really this treatment paradox where our highest risk cases often have the greatest incremental benefit from a procedure, but can often be the least likely to be done due to the increased risk of the procedure, the increased complexity, the novel equipment that's needed. And so the goal was to bring in someone to help lead a program to develop a type of care for these types of patients, because again, this patient group continues to grow. It's grown beyond just sort of a niche population treated at the universities or some places far off. These are our everyday patients walking in across the street, and we need to rise to the challenge of being able to care for these patients on a day-to-day basis. So who are the types of patients now that we've gotten a little bit of clarity, a little bit more granularity in that regard? Well, there's two big pillars in a type of program with this, and that's treating patients with complex disease and treating patients who are quite sick or in shock. And shock is just a general term, which means my body's not getting what it needs and is starting to shut down. So phase one of the program is really tackling these patients with complex disease, which is what we're currently doing. In phase two, we'll be looking at more of these patients in shock and continuing to support them with various types of devices. These are angiograms, which are pictures that interventional cardiologists like Dr. Vilas and myself do on a routine basis in patients with symptoms. And these angiograms, we don't have to go into the details of what they mean, but you can see that these sort of strings that go down are arteries of the heart. And again, I don't think you have to be a physician to be able to look at these strings and see that there's a lot of divots, right? There's a lot of blockages in these strings. And so the types of patients that the program we're developing are the patients who, for example, have a lot of blockages and the surgeons say, hey, I don't think that we can possibly operate on them because either there's nowhere I can put a bypass graft or they're too sick. These are the types of patients we take care of. And on the right here is after we're able to take care of these types of patients using specialized devices, including machines that can help the heart that's sick during these types of procedures. The no options patients, I get these frequently. Oh, the interventional cardiologist said, I can't have stents, it's too complex. And the surgeon said that they can't fix me, what do I do? And we're able to oftentimes provide patients with options, as you can see on the right, after fixing them. There's the too hard patient, meaning their disease is too rock hard. As disease in our arteries matures, it can become rock hard. And in fact, if you take a slice of it and look at it under a microscope, it looks just like bone. And a lot of times people say, I'm sorry, we can't fix that. But with new technology that's coming around the pipe, we actually can fix those patients. For the too sick patient, so there's patients that are just too sick for certain types of surgeries or stents. And again, we're developing a program to help those types of patients. And then there's the too difficult. Too many people have failed. It can't be done. But again, with novel training, with novel procedures, with novel techniques, with novel equipment, these things can be done. So what does developing that type of program here at Overlake look like? Well, one thing about healthcare, and we've touched on this a little bit, but healthcare is becoming more of a team sport because patients are getting more complex, right? There's lots of things going on, and to pretend that one physician or one nurse or one care team even can provide everything a patient needs is a little bit antiquated. And so we're evolving to develop team-based care models where multiple physicians are able to come together, look at a patient, put into the patient's needs and desires into a sort of an overall look and say, what's the best thing for the patient? And it's not from a top-down approach, right? It's not the doctors coming and saying, here's what's for you. It's integrating the patient in with different types of specialties and saying, what's the best thing for this patient? We have a heart team meeting that occurs here at Overlake that was really started around what Ron was talking about, the structural or valvular disease. And we're extrapolating that to the entire heart now that we have a program for patients with complex coronary disease. We have weekly meetings with our surgeons, interventional cardiologists dedicated to complex imaging to, again, try and look at these patients in more of a 3D view to get multiple opinions. We have coordinators who help coordinate care. Once we do decide that there's something we can do for a patient, these are dedicated nurses and nurse practitioners that really help our patients from A to Z. They reach out, help set up the visit, collate all of the information that's needed to take care of these patients. There's so many things from other hospitals and imaging tests so that we can have an efficient ability to see the patient again in 3 dimensions. They then help in our heart team meeting coalesce this information. They're the point of contact for the patients as they go through referral all the way to clinic visit, all the way to the procedure and on the other end. And these are key to helping our patients really feel like they are cared for well during the entire procedure from our entire team. I was lucky to do this at a prior institution, so have had some experience doing this. I've been in Cincinnati at a large hospital for the past 5 years, building the same type of program. And we went from a very small number of procedures to one of the busiest cath labs in the United States. I was lucky enough to see patients from a 6 or 7 state radius, as can be seen here. And we're already starting to see the radius of care for the types of patients we deliver here start to expand. Even in the past couple of months that I've been here, we're seeing patients from Idaho, Bellingham, all over the place, which is really exciting. We were able to become one of the busiest complex coronary programs in the United States at my old job. We became a regional and national learning center. Physicians would come from all over the nation to learn how to do these procedures, listen to lectures given by myself and my colleagues. We were routinely testing novel products first in man. I'm lucky enough to edit an international newsletter about this topic on a monthly basis, as can be seen on the right. I am also lucky to speak on this subject matter on a routine basis and speak quite often all over the world. We had major research endeavors at our prior institution, and I was lucky to become an endowed chair towards the end of my time as part of a research endowment for our patients. I was also lucky to write the guidelines for treating patients with complex disease. I was actually the main author of that manuscript last year. So let's talk about a few patients, because all of this can be a little bit esoteric, right? Looking at angiograms and trying to understand the complexity, but really, I think whether you're a healthcare provider or not, really hearing patient stories puts a lot of this on paper and helps us crystallize some of these ideas. Also, it's really weird doing this without seeing anybody's face. So I hope I'm not looking off screen or something like that. But not seeing people face to face and doing this, even after 2 years, continues to be just a little bit odd. But this first case is a dear friend, a 79-year-old gentleman admitted, actually, interestingly, with depression. He was a former CEO of a large bank with a PhD in economics, and had found himself at the end of his life just more depressed, and actually was admitted for it, and interestingly had a heart attack during his hospitalization. We didn't know it then, but his depression was actually a direct cause by his heart disease that was undiagnosed at that time. The original cardiology team at the other hospital got involved and found his heart to be very weak, and they ended up taking some pictures and found him to have extremely complex coronary artery disease. He unfortunately was deemed to be too difficult by the surgeon and interventional cardiologist there. So my team was contacted, and the patient was actually transferred to my center at the time. We had a long discussion with the patient about the pros and cons of various types of treatment option modalities, and we ultimately ended up being able to treat him with stents using a special device implanted into the heart. It's a little machine that's actually able to help the heart pump during the procedure. We were then able to use special types of drills and different types of things to get out the very difficult, hard to treat plaque, and then put stents in and ultimately fix all of his arteries. The patient did very well, had complete recovery of his heart function, and we still actually visit today. This is Dr. Chuck Thiemann, and it's okay. This is not a HIPAA violation because this has been in local and national newspapers the story was picked up, just lucky to do that. And he was actually one of the first people treated in our program. These are some of the colleagues that I worked with at the time, and actually this is how our foundation started at my prior institution. The second case that's relatively illustrative of what we try to do, this is a very healthy 58-year-old female who really had very little medical history. She had had one stent during a heart attack several years back, but again, worked out all the time, very healthy. Unfortunately, over the years after her stent had developed some very dangerous heart rhythms and needed what's called a shock box or an ICD. This box unfortunately continued to fire and nobody could really figure out why. This became difficult as she wasn't able to drive because of that, and she still actually had kids in high school and was not able to take them to high school. And you might think 58-year-old with kids in high school, don't be too judgmental because I also will be a late 50-year-old with kids in high school. So please don't judge too harshly. But this woman really, I remember she came to my office in tears, just sobbing because she couldn't do anything. She couldn't take her kids to high school and she felt like her life was ruined. She had been I was the fourth interventional cardiologist she'd seen at that time. The angiograms had shown that the stent they had put in one of the arteries had completely closed. She had unfortunately undergone 3 separate attempts to try and fix it. She had been referred to surgery, which the patient did not want, and was realistically probably not indicated for the type of disease that she had. She was referred to me again as a 4th attempt at that time. We had a long discussion and the procedure was scheduled. We were able to fix her, thankfully, in a couple of hours and get her artery completely open. And it was extremely nice to hear from her on the back end because she was able to tell me she was back to driving, doing what she wanted, and her shock box hadn't fired in a couple of years the last time she and I spoke. So where does philanthropy come in? Because again, this is a team-based sport. One of the big parts of programs like this is we continue to build and look at the complexity of the types of patients that we care. We're always looking for ways for patients to give back because these are important things. When people are thankful, we always want to find ways to let them be thankful and show their thanks. That's important from not just a hospital standpoint, but from a care delivery standpoint. It's important to let people get back in whatever way that looks like, whether it's contributions, telling their stories to staff, news, paper articles, or just writing a letter. These are very important things. And then utilizing our foundation for further program development, whether it's research projects, staff development, indigent care, equipment purchases, upgrades. And this is actually an example of one of our ongoing projects utilizing this is our new Cath lab that'll be developed. It's going to be state-of-the-art with state-of-the-art radiation protection, which is going to allow our staff to not have to wear heavy lead during their procedures. This is going to improve orthopedic complications from our staff, our physicians. This is going to improve overall quality of life for everybody and particularly reduce radiation for our patients as they undergo these procedures. It's going to have the latest and greatest in terms of being able to deliver the types of care that we just talked about. There's future needs with all sorts of things as they come out because this is a dynamic field. But again, these are the important partnerships that talk about why this is a team sport. So in conclusion, heart disease continues to increase in prevalence and complexity. We spent a little bit of time talking about that. A formal complex coronary therapeutics will allow us at Overlake to provide data-driven, patient-centered treatment strategies for our growing group of these patients with very complex heart disease. This does take a dedicated team, which we have here. We have precedents for here at Overlake, and we're continuing to grow and expand that. People with particular training and experience are being recruited for this team. And again, we have a history of doing that, and it's going to be exciting to transition that over to this new team that's being formed. And again, I can't emphasize this enough. We cannot build these types of programs, care for these types of patients, and be what Overlake needs to be for our community without our partnerships with you all. So again, I just want to thank you all so much for joining us for sort of this informative talk about the program that we're doing here, about our vision, our goals, and again, ways that we can continue to partner with you all on taking care of our patients. So thank you guys so much.
Thank you, Dr. Riley. That was wonderful. And I appreciate also you calling out the importance of philanthropy. Almost everyone on this call is here because they are a generous donor and they have contributed to the hospital, many to the cardiology program in particular. And I know that there is a deep interest and loyalty and pride in what they have helped build here. So I think I speak for everyone in that category on this call. So thank you. Fun to hear about what's coming. So there are questions. Please, at this point, everyone will, you can put a question in the chat. You can raise your hand. There were questions submitted ahead of time, and I'll start with a few of those while we wait to see what other questions come up. And also, Mike is here and is also willing to take questions on topics related to Overlake. I've got a little bit of an echo. Sorry about that. First question, really lots of questions related to lifestyle and risk factors. So if you could address what risk factors are most useful to target for reducing the overall impact of cardiovascular disease, and then part two, what behavior changes could have the single biggest impact. So that's a lot, but it covers about 6 questions that were submitted ahead of time, just lifestyle questions and risk factors and what's most important to watch for.
Sure. I want to start off by saying that there's no, like anything in life, there's no easy answers. There's no one size fits all. And this is why relationships with your physicians are so important, because these types of questions have to be taken in context. We can certainly go over some general overview thoughts on that, but again, it is a little bit tailored to every patient. What I always tell patients when they ask me these things is that you don't have to be a physician to know the answer to most of these things. Most of us kind of know these things. Sometimes we just need a little bit of a boost, a little bit of a push. First and foremost, not smoking. That's actually the #1 risk factor for cardiovascular disease above everything else. But, living here in 2022, particularly on the East Side, tobacco use is not as prevalent as it once was when I certainly practiced in the Midwest, and certainly when I started 15 years ago or so. It is just of note increasing in frequency in our younger population, particularly our younger 20s. And so we do sort of have to watch that. But again, if there's one thing that happens to be on the list of things for a person, that actually trumps everything else. Then we work our way down to just exercise on a routine basis. The American Heart Association recommends that we do aerobic activity most days of the week. What does most days of the week mean? It means most days of the week, more often than not, right? At least 30 minutes of getting your heart rate up there. There are particular criteria. Those are not really worth getting into. It's just getting out and being active for 30 minutes a day. They do also recommend anaerobic, meaning weight strengthening, at least 2 times a week. And again, that's important, especially as we get older, because maintaining our muscle tone will actually help us stay mobile. And as you all know, again, you don't have to be a physician to know that once your mobility goes, everything else kind of tumbles after. Then we start talking about things like blood pressure management, which again is a little bit patient by patient, but again, that's particularly important. We routinely measure cholesterol, which again, a little bit patient by patient, but extremely important there. Diet, again, don't have to be a doctor. We know most of the things. Again, we just need a little bit of a reminder. Keeping our red meat to at least 1 to 2, no, not at least, to just 1 to 2 times a week. Trying to get more fish in our diet, which we're thankfully, we live in a place that we live where that's a little bit easier. Trying to limit complex carbohydrates, and then, focusing in on fruits and vegetables. These are sort of the main things outside of some more nuanced things that might be, particular to certain particular patients and things like that.
Good answer. And darn it, we know our conscience should be our guide, I think is what you're telling us. So a couple of questions on plaque, and you mentioned it in your talk. One question had to do with, can vitamin K7 reduce plaque? And another question was, are there calcium tests that can detect it?
Sure. So I don't have much to say about supplements for a variety of reasons. The most important being that they're not FDA evaluated. And so as a physician, I'm a little bit hamstrung in the sense that by not being evaluated by the FDA from a medical, legal, ethical standpoint, it's a little bit difficult to speak to that. As most people on this call probably know, supplements don't have the same regulatory pathway that approved medications do. And so the variability in dosing and all sorts of things can be challenging. So I don't usually speak to supplements much. It's not that I have any problem with them or that there aren't good ones. It's just that it's a little bit, again, from a medical legal standpoint, difficult to speak to that. There are ways of detecting risk for heart disease, particularly calcium in heart arteries. The most prominent one at this point is what's called a coronary calcium score. It's a quick, relatively painless CT scan that just looks for calcium in the heart arteries. The reason it looks for calcium is that as plaque forms, it's initially quite soft. It's made up of this kind of cholesterol and things like that. As it matures, it actually grabs onto calcium. That's just what plaque does. And so what we look for on these coronary calcium scores, any evidence of calcium along the arteries. An absence of calcium typically means that there is an absence of disease, although it's not 100%. Again, a little bit of it depends on the patient, how they come in, what their symptoms are, and things like that. But for the average person who comes in, who's at what we call intermediate risk, we will often do that type of scan to say, do you have any disease at all? And that can help push us forward on types of blood pressure medications, types of cholesterol lowering medications, and things like that. But again, that's a little bit patient-centered, patient-specific. But yes, there are tests that you can discuss with your physician about that.
So Brian has a question. He actually just posted up here. He submitted it ahead of time too. It was about glucose levels. And what is it about high glucose levels in the blood that put someone at increased risk for heart disease?
Sure. So I always tell people I try and stay in my sandbox, right? Like I stay in the little heart sandbox. And so I try not to play in other people's sandbox too much because I just get all messy and don't know what I'm doing. So, so I'm not an endocrinologist or a diabetologist, but what I can tell you about diabetes and elevated blood glucose levels, and much of what we've learned about glucose's effect on heart arteries comes from a lot of our diabetes literature. Elevated glucose levels on a routine basis lead to increased inflammation. And that's why we see all sorts of things like high blood pressure, kidney disease, heart disease. It's really this inflammatory condition. And that's really what heart disease is, actually, is chronic inflammation of the artery beds that actually lead to this plaque formation, hardening, and these types of things. And so when you have a disease process, diabetes, that leads to chronic inflammation, it is a much increased risk for this types of disease. In fact, when someone has diabetes, we call it a risk equivalent for heart disease, meaning if you have diabetes, you really essentially have to treat the person like they have heart disease because of this chronic inflammation. Now, there's obviously a spectrum there from the well-controlled diabetic to the uncontrolled diabetic. But again, because of that inflammation, we consider that to be sort of like an equivalent there. That chronic inflammation leads to friability of the artery beds themselves, which leads to an increased preponderance to take up plaque. And then obviously, as plaque builds up, it increases for heart attack, blockages, things like that.
Interesting. All right. What is the average age of patients served by this program, by the CCT program? And is there a point where someone is just too old for CCT?
That's a really great question. So we don't have an average age here because we just started a few months ago. I would say the average age at my prior program, if I remember offhand, I think was 69 or something like that. And so it is certainly an older population, but again, that's not surprising because as you get older, you sort of build up more and more health issues, right? And also, as you get older, there's going to be more prohibitive things where things like surgery and other types of things are going to be a little bit more off the table. So there's no age cutoff, right? So I would never say someone's too old. I would say that we know that our risk of procedures goes up as we get older. So the discussion on pros and cons does shift a little bit as we get older, but I've taken care of, 91-year-old people in this type of program. I've taken care of 37-year-old people in this type of program. So there's really quite a wide age range. And I would never say that someone's too old. I would say it sort of depends on the patient and what their wishes are, what their family wishes are, what their pros and cons, what they really want to get out of these types of things is. And so, again, everything has to be contextualized to the patient, their situation.
So there's another one in the chat, but there's one more that was submitted earlier that you haven't touched on. You actually talked about radiation and lessening radiation and the importance of that for the folks, the care team. This question is, how much imaging radiation can heart valves take?
So there's no There's no cap on radiation that heart valves take. Heart valves typically, the types of tests that we do for heart valves often don't involve radiation. So when we think about echocardiograms or ultrasounds of the heart, there's no radiation there. Those are just ultrasound waves, which actually don't have any sort of deleterious effect on the heart or the valves. Sometimes we can do other types of imaging, such as MRIs, which again don't have any harmful radiation there. We can do CT scans, which are essentially just X-rays stacked up on each other. That's certainly an amount of radiation, but the likelihood of utilizing that on a recurrent basis for valves is somewhat less. We can use those in the planning stages for certain types of procedures like Dr. Aviles does, where we replace heart valves from an IV in the leg. But again, that's not usually a recurrent theme in that regard. Now, there's obviously radiation limitations outside of just looking at valves, where we talk about how long of a procedure can you do, and we have certain cut points where we know above those cut points patients get at risk for radiation-induced, injuries and things like that. But again, we keep pretty tight control on that, monitoring that during these types of cases.
Okay. So here's a question from a former nurse. Do you ever check homocysteine levels to predict heart issues? And I'm sorry if I'm pronouncing that wrong. I'm not sure if you're seeing the chat, Rob, but homocysteine levels as a prediction of heart issues.
Sure, not monitoring the chat because I'm just trying to give you my,
you don't have to. I'm doing
the
it
screen.
for you, but
yeah, I appreciate that. So homocysteine levels. So there are a few markers of inflammation that have been associated with increased risk for cardiovascular disease. Things like homocysteine and CRP. These are inflammatory markers, actually. And as we discussed, heart disease is an inflammatory process. So there have been links with people with elevated markers of these two things with increased risk of disease. The challenge is there's not been any data that routine monitoring of these things necessarily changes someone's long-term outcome. For example, I had somebody come to me recently, a young person with an elevated CRP. Same basic idea as homocysteine. The challenge is I have no data to say that if I do something to lower that level, does that mean that I affect their long-term outcomes? And one of the things that we always struggle with is if I'm going to do something to you, whether it be a medication or a procedure, there has to be something for you in it in the end, right? I have to be providing you some benefit. And if I'm just doing something to treat a number without knowing whether it's actually going to give you a good long-term outcome, well, I'm not really practicing medicine, right? I'm just treating a number. And so that's the challenge with some of these markers like homocysteine and CRP at this time.
Mm-hmm. All right. How long should a stent last? How long?
Sure.
And how can they be checked?
Yeah, that's a great question. So this has evolved over the years as stent technology has improved and as we've figured out how to sort of follow patients with these types of devices over the years. Stent technology has improved dramatically over the past 5 to 10 years to the point now where in the routine patient, stent failure rates are somewhere between 5 and 7% at 5 years. And so this is a routine question patients ask, and I say, well, it's unlikely it'll fail, but it's not zero. Now that risk of failure does feedback here. That risk does go up substantially as the disease burden becomes more complex. So for example, in my patients with 100% blocked arteries that I treat, that failure rate can go up in the 10 to 12% range. So again, it's not likely, but it's certainly there. And one of the challenges is because when we put stents in, we are not actually treating the disease. And that's a hard thing to kind of get your head around, but the disease is still there. All we're doing is squishing the plaque out of the way and putting a stent there. That inflammatory process that we talked about, that type of thing, that's still there, right? Those people still have coronary disease. They just have their blockage fixed. And that's why we have to really harp and continue to really be aggressive on cholesterol, blood pressure, lifestyle, and all of these different types of things. And that's why that relationship with your care provider remains so important even after you get fixed, with a stent or bypass.
All right, here's one about the CCT program. Can you estimate how many cases a year you will be doing once the program is well established? Granted, given that you're just starting, I mean, what does a fully blown program look like?
Mm-hmm. Is this from one of our administrators? Is that one a board member that's posing?
Not Mike.
Okay.
It's not Mike, but Mike, you might want to ask him that too. I don't know.
Yeah, apparently it's budget time and we're just sort of double dipping here. That's fine. So, one of the things that Ron and I talked about, Ron's been doing, Dr. Vilas has been doing this for a long time, longer than I have. And, we had a large program back in Cincinnati, again, one of the largest in the United States, actually. And we were doing a lot of procedures. I personally was doing over about 500 a year. And then, 200 and 250 of those were these core complex ones. But every place is different, right? Every group of patients is different. Every community is different. And so what we have to do is, what we're not trying to do is take the same program and put it here at Overlake. What we're trying to do is figure out how this program fits at Overlake. How do we serve our patients the best with this program? And so, what we don't have some goal. We need to do this number to be successful. What we want to do is create a program that meets the number of patients that we service fully. So if that ends up being 50 a year, great. If that ends up being 200 a year, great. But as long as we are caring for the patients that come through our doors to the best of our ability, then we've done our job and the program will be successful. And so what we don't focus on necessarily is numbers per se. What we focus in is the quality of the procedures that we do for the patients that we care for. I hope that makes some sense. It's a little bit of a dodge, but I think it's true.
Yeah, it makes
So
sense.
I'm
I don't know,
gonna-
Mike, if you want to chime in, you get your administrative response time.
Yeah, actually, one of the things I'm going to
Oh,
say
Ron, okay.
to that, and I completely want to echo what Robert said, actually, but something important to speak to is the opportunity, the opportunity that brings to Overlake Hospital, and while we can't quantify exactly, a number or what that's going to look like, we can certainly estimate what the opportunity means. And over the years, we have created important partnerships at Overlake Hospital. We've created partnerships with Kaiser Cardiology, and a lot of, for instance, the structural heart program, comes with a partnership with Kaiser, and a lot of those patients come to Overlake to be served because of the platform we've created for care. We also have a partnership with Evergreen Hospital, and a lot of those patients actually that need advanced tertiary care now come to Overlake Hospital to serve patients on the east side. So we have already a momentum of partnerships, I think, that holds a lot of these patients that require advanced care. So I want to say something about the partnerships, to create, the type of volume that's necessary on a backdrop of high quality, like Robert is speaking about and provides. There's also the fact that in Western Washington, there's only one other team that provides this type of care. No one else. North to south, east to west, there's only one other team. So this is the second team in Western Washington that provides that care, and probably one of the administrators can tell you how many hospitals we have in the state of Washington, and we're talking about 2 hospitals having that type of tertiary capability. So while a number cannot be defined, what we can control is the opportunity, the partnerships we provide, and care of the highest quality to deliver, and that comes by the people. It comes by the platforms and the investments that have occurred, not today because Robert joined the team 3 months ago, but because of the investment that has continuously been done in our service line over the last 8 years. So this is but harvest season to really capitalize on all that investment, having created the opportunity to provide that type of care. So I expect that, number one, our program is going to be of the highest quality in the state of Washington. And number two, that it's going to continue to grow because success begets success. And we'll start to hear some of those patient stories, like Robert said, and that's just going to generate, more of it. And that's what we've seen in every carefully thought, deployed program that we have had at Overlake Hospital the last 8 years. So I'm excited about that.
Great answer. And Mike has responded, 112 hospitals in the state. So, and there are two of the 112 who do this CCT procedures. So, there was a question earlier and you're both great. Ron, you probably could help answer this as well as Robert. If you're already a patient in Overlake's cardio program, how do you get into the CCT program? I think it's a matter of, you might want to address how how patients are referred for this particular procedure. I believe that's what you're asking, Craig.
Yes. So, so because, our patients come from different places, they come from Kaiser, they come from Evergreen, and they come from outside of Overlake, at this point, a lot of that access, comes through our normal access to cardiology, and then get routed, to Robert, if the case, warrants that, and it's happening a little bit organic now. As we pick up momentum, and we continue to build that program, and mature the program as we expect, I think we're gonna be able to build a little more visibility, a little more online presence, for access. We're gonna be able to have, staffing. We built, even before Robert got here, we built a business plan around how we're going to deploy those resources to be able to do enhanced program and access specifically to the program. But, for the time being, access is really in the same way that any other cardiology patient gets access. And internally, those patients get routed. For instance, if somebody thinks they need to go to the CCT program, but it turns out that they have mitral valve regurgitation, then a lot of those patients are not going to get routed to Robert, but rather, to me instead, to be treated for be considered for catheter-based therapies for valve disease. So it just, it depends. Right now it's internal, but there's a whole, plan, both clinical and business, to develop the program in the next few years. And the key thing is to, again, have the highest quality people to deliver it, and you've heard from one today. So
excellent. There's a question related to the new equipment that you referenced, and when will it become operational? Mike put the date in the chat, November, December, either next November or December of 2022. So it takes that long to order it and get it installed, but it's in process. And I think that, though, it begs the question, the procedures can be done now. The new room will just help with that. Isn't that the case? So it's not like we're waiting for the new room to become operational before someone could have a CCT procedure here.
Correct. So just to be clear about that, we're already doing these procedures now, and have been since we kind of hit the ground running. Yeah. The new room is really sort of like what Ron was already saying. Overlake's been building this sort of desire to continue to expand cardiovascular services to meet our patients where they are for years and years now. You see that with the imaging side of things. You see that with the structural program that Dr. Aviles leads. And now we're just adding this on. We're doing those procedures now. We're just continuing to build out ways to do it where we can be a little bit more efficient. Again, incorporate novel technologies as they come through. But it's really, it's a never-ending sort of build, and continuing to incorporate new equipment as it comes, and continuing to sort of be, deliver the best care that we can. So again, we're already doing those. We're just getting some new space to do even more.
Mm-hmm. Right. Great answer. There's a lot of talk about the Watchman procedure, and someone is asking about how has the Watchman procedure affected stroke risk, and what percentage of patients who get it no longer have to be on anticoags. But you might explain Watchman, because it's something people read about and not a lot of people understand what it is.
So we're going to take the fifth on that one, because we need another Circle of Excellence meeting about that. So I like to tell people that actually the heart is a little bit like my house. There's a power and electricity that comes to it. There's the structure of the house. There's the plumbing that comes to the house. So what we have been talking this whole time with Robert has been the plumbing of the heart. And that's as you heard from Robert, that's a whole field in of itself that is wide and expanding with lots of expertise, and the structural space, which is the house itself, is a whole thing in itself as well, and we don't have the time to get into that. But the Watchman fits into the structural space of how we cope with disease in the heart to prevent stroke in patients with atrial fibrillation. So I'm probably going to leave it at that because we would need another hour and a separate time to really discuss that separate field. And I don't want to get into structural heart today. I really want to keep us on the plumbing state.
Well, we'll take that as a yes, that you would come back at a later date to get into the other side of the business.
Always happy to, Molly. Always happy to.
That sounds great. There are a couple other questions, but we're getting short on time. The final one that I see up here that we haven't addressed, it has to do again with blood thinning. Naturally occurring substances such as garlic. Are these, are these comparable to baby aspirin? The old take one aspirin a day to keep your blood thinner to avoid heart disease. I think that's the gist of what you're asking, Brian. Any response on that, Robert, that you want to, just in terms of blood thinning tech, the best ways to, best blood thinning.
Sure.
Things.
So first,
I'm not a clinician. Clearly, I'm not a clinician.
Yeah. So first, to the person that wants to take daily garlic, good for you. That's brave. That is brave. No, I mean, one of the challenges, and I'll go back to what I said earlier, it's often difficult to speak about supplements or non-FDA indicated treatments or evaluated treatments. There's certainly been no study to show whether garlic would sort of prevent or lower your risk of a heart attack, like there has been with aspirin in certain populations. There's been no evaluation of it in terms of keeping stents open, like there would be with aspirin, or stroke prevention. So there's not an ability for me to necessarily speak to that because there's simply no data. So as a physician, if you were indicated for aspirin, there'd be no way that I could recommend that. And again, it's not that there's necessarily anything wrong with garlic. It's just that we have no data to sort of show you that would be an acceptable alternative there.
Well, Mike, our CEO has answered it for you, Robert. He has just put in the chat that garlic is good to ward off vampires, though. So
I almost went with a vampire joke, but I'm glad Mike fell on that sword. Thanks for. I was just thinking, what would my breath, like? Would I stay married? Like, would I have to wear a mask even when COVID was over? I don't know. Anyway, it's a good question.
All right. Yeah, there's a lot out in the press and lots we don't know and a lot we do know. And boy, but we've all learned a lot from you today. So thank you. Thank you so much. This has been wonderful. And thanks to Dr. Vilas, who's off camera at the moment. Thank you, Mike, for helping to kick us off and help make possible, along with the donors that are growing and advancing cardiac program. Just again, and thanks to all of you who are here and who are helping us do what we do at Overlake, which is provide world-class care to everyone we treat. Shortly, you'll be receiving a follow-up survey. Please take it. We really do listen to what you say. It helps us with future topics as we bring you back together again. And we really do want to get your feedback. So please do respond. It'll take you 2 minutes. There'll be a recording of this event, which we will send out to everybody soon, within the next day or so. So please feel free to pass it on. There's been a lot of good information shared, and we would love to keep educating as many people as we can through your own network. So thank you again. We'll keep you posted for an upcoming Spring Circle of Excellence event, which is in the planning stages. And just take care of yourselves, everybody. Have a great weekend, and we're done. Thanks so much. Take care.
Thank you, Molly.
Yeah, thank you both so much. Bye-bye.